panel members. So at this point, I want to open it up to the question and answer session.
Okay, folks, now you've had a little bit of wine. Hopefully you've written down a few questions that you might want to ask of our panel. Before we go to our Q&A, I am going to just bring up our panel and allow them to introduce themselves. We're really pleased to bring you a variety of experts that can address your questions, and I'll start with Val. Valerie is from the Women and Children's Hospital in Buffalo. Val is the former administrator over radiology and has worked on dose optimization for many years, and so she'll bring a length of experience as well as has lectured on the dose index registry from ACR. John Ferguson is the administrator over Adventist Health Radiology on the West Coast. John has responsibility for more than 20 hospitals within Adventist Health, and so he can bring the experience of a large enterprise system as well as working locally in the Portland area. And then Dustin Gress is a medical physicist from MD Anderson, and Dustin was a former consulting physicist, now at MD Anderson, and has quite a lot of experience in optimization of protocols and working with clients prior to dose tracking software being available, and now is using dose tracking software. So please do not be shy. We want to give you this opportunity to ask questions of our panel, but before we do that, they're each going to spend a few minutes just talking about some of their experiences. So let's start with Val.
Okay, my name is Val Cronin. I'm from Buffalo, New York, and thank you for giving me the opportunity to be here. I'm a nuclear medicine technologist by training. I graduated from St. Bonaventure University, got my graduate degree in HSA from Duville College. I went on to become a fellow of the Society of Nuclear Medicine and later served as president of the Society of Nuclear Medicine Technologist section. I also was president of the Education Research Foundation for Molecular Imaging Board and served on that board for 10 years. And although the first part of my career was kind of in nuclear medicine dedicated, the second half was based on imaging administration, where I served as vice president of a healthcare system in Buffalo, COO of a neurological imaging center, and then most recently spent time at Women and Children's Hospital, where our main focus was lowering dose for patients, pediatric patients. We were probably one of the early onset users of the ACR DIR. So those are my experiences. I hope they make me sound knowledgeable and not just really, really old. Thank you.
So my name is John Ferguson. I have about 35 years of experience in radiology. I'm actually working now more closely with laboratory sciences and patient blood management. So I love to be able to spend some time in imaging now. But I started off over 35 years ago at Loma Linda, I think the third CT in the country, doing CT scans with Roland Reines. A lot of you know him. He actually taught me CT, and CT is really my first love, and I was able to actually then leave CT and work in radiology administration basically the last 30 years. But one of the things that I've focused on in my corporation, looking at how best can we actually standardize and look at what we do across the 20 hospitals. And I have currently 4 critical access hospitals and 16 medium to larger size hospitals, and so there's a lot of variation across the system. And one of the things that we're going through, and I think a lot of IDNs are going through this, is M&A, and that's merger and acquisition. So what happens when you have M&A? Well, there's limited capital to go out and buy dose monitoring software, and there's also lack of IT resources to invest in actually the integration. So that's one of the challenges. So I worked with my 20 directors and said, how best can we actually help, improve patient radiation safety? And the thing that we've been focusing on within Evidence Health is standardizing our policies and procedures for both MR and radiation safety, and this is an area that we have really focused on, so we're going to have a standard policies and procedures to be able to address all the issues within the new Joint Commission requirements. We've also established and utilized the Landauer Academy that they have actually made available to us, and we've actually put that on our health stream so that all the courses that are available, both for physicians and technologists, we have actually integrated that within our 20 hospital system. And so I think that's been a real plus moving forward. During our review process of actually drilling down into our policies and procedures, we started looking at the Joint Commission requirements, and we actually identified best practice within our 20 hospitals and then wanted to emulate what they do as far as actually how do they actually meet the standard actually without going out and purchasing a dose monitoring product, and basically taking the technologist who's doing the CT scan, basically having them do what they were trained to do, is provide the best and safest experience for that patient and make sure that that dose is not exceeding the dose prescribed. So that's our experience.
My name's Dustin Gress. I spent almost 7.5 years consulting for my dear friend and mentor, Bob Pizzatello. And then I had an opportunity at the end of 2011 to, my family and I decided was best for us, which is to take a position at MD Anderson Cancer Center. So I went from consulting for, a couple hundred clients and across the Midwest and Northeast to being one of about 24 imaging physicists in the Department of Imaging Physics at a large cancer hospital. So we do something like 1.3 million outpatient procedures a year rather. We've got, 22 or so standalone CTs. We do between 70 and 100 PET CT patients a day. And one of the reasons I went there was to get some more in-depth nuclear medicine training, nuclear medicine physics, and so I'm boarded in that, and I support the nuclear medicine and PET clinic. I support CT, I support mammography, I support IR, I support radionuclide therapies, including Y90s. So I've had a pretty broad range of experience, and I guess I'll just leave it at that.
Excellent. So now this is your opportunity. You have a panel who has experience, and now we're looking to hear some of your questions. So we do have a microphone over here, and in a moment I'll bring it to you. But let's start out, Olav. You have a couple of questions that you think everyone's going to want to know. So why don't you start us off with a few just to warm up the crowd?
Yeah, so one of the questions that always comes up is what is the cost of implementing a dose monitoring program? And Dustin, maybe you can share your experiences with doing that as a consulting physicist.
Sure, absolutely. So one of the projects that I did just sort of as I was, it actually assisted me, Bob, in landing my position at MD Anderson because the experience was very valuable. So back in roughly 2010, there's a facility in Connecticut who had a very ambitious radiologist who worked in private practice, and she's since moved on to Harvard Medical School and MGH and Dana-Farber. So she's done great things. So she wanted to do a protocol review project, and so we did, and we picked the lowest hanging fruit, which is the adult head protocol. And they had a GE 16, they had GE 4 slice, they had a Philips 64 and a Siemens definition 40. And they had, of course, wildly variable image quality results and CTDI results, and we spent some time and we published our results. It was eventually published in 2012. There was a poster in 2011 at RSNA. So the work was done basically in 2010 and 2011. And we were able to, for the first time and the only time that I've seen, actually quantify. And if you account for 4 CTs, 30 protocols per CT, which I know is adorable, right? 30 protocols on a CT. It comes out to, according to the hours that we spent, about 165K. For the person hours, we spent a total of 57 person hours for one protocol on one CT. Now, I did say at the outset we picked like the lowest hanging fruit. So that protocol itself is unrepresentative of the rest of them because it's the easiest. But I can tell you that some of the hours was spent collecting and doing analysis on the data. If you have a system that will just do that for you, then a lot of those hours go away. And the hours that you're spending actually being productive, having productive conversations about strategy and where you're going, those are the bulk of the hours. So so that's, the data is out there, and that's 2010, 2011 dollars. Of course, we're a few years since then. But that publication is available in the JACR. It's my only publication. You can just search my name; it should pop up.
The only one yet.
Well, the only one in the JACR, yeah. I have
know
another
that
one.
there will
yeah.
be more.
Yeah.
By show of hands, how many of you had contemplated tackling these new challenges with a manual effort? It's reasonable. And by show of hands, how many have begun to make investments in either a dose tracking system or your physicist is doing dose optimization for you? Yeah, so about 50-50 in the crowd. Olav has some results from a study that we've done, and of course you saw the one from Aunt Minnie as well. Excellent. Would anyone like to venture a question? We do have a microphone over here if you want to come up to the podium, or I can come to you. All right, great, thank you.
You mentioned that when you have a dose that exceeds, that it should be reported. I know immediately it's reported to the radiologist and to the tech that did the overdose. But where should it be reported as far as the Radiation Safety Committee, or should it be the QA committee of the imaging department? What do you recommend? Right now we're doing it at the Radiation Safety Committee.
I can speak to that. Once you have something that has exceeded a dose, hopefully your hospital has instituted a dose reduction committee. I don't know if you've had that, or is everyone familiar with a dose reduction committee in your hospital? It's a separate committee than your radiation safety. That committee usually is a medical technologist, your radiologist, your lead tech, and your manager. And it has a vision and a mission statement, and it focuses just on lowering dose. So I would think if that committee were to meet quarterly, any case or study that exceeded the dose, that would be the perfect place to discuss it. But then I think it should also be reported at your radiation safety committee also. I think every hospital, and it's up to every hospital, how often do you want to review these cases? Do you want to review them, every 2 weeks if you're a very big hospital, or every quarter, or every 6 months? But in the beginning, I would think you would want to get a handle on it to make sure you're capturing it. So I would recommend a radiation dose committee that's just focusing on lowering doses, not only in CT, but nuclear medicine and fluoroscopy and digital imaging also.
Val, can you talk a little bit about the executive sponsorship within Women and Children's for that new dose committee that you formed?
We were probably the first ones in Buffalo to form a radiation dose committee. And I think we were very focused on it. Our hospital was a little different because we're planning a new hospital that's going to be opened up in 2017, a new children's hospital. So we wanted to perfect all of our protocols, all of our radiation doses, so that what we moved to the new hospital was going to be the safest possible hospital for any pediatric patient in Buffalo. We wanted all the children to come to us. So our administration was very supportive of it. And then actually, we did a lot of work with the AHRA, actually showing our data and how we were able to get that data back, bring it to the dose reduction committee, and with the medical physicist, focus on some of our cases. We focused initially on our highest volume scans, and those scans that also were flagged by the AHRA, DIR, as being above the accepted ranges of other benchmark hospitals. When you send your pediatric data to the AHRA, it's not only capturing the pediatric data under the age of 18, but it breaks it down into subgroups, 0 to 2 years old, 3 to 6 years old, 7 to 12 years old. So you have all these little buckets with different children in different sizes. So it can get to be an enormous process if you look at it and you think, where do I start here? So we started with those. But our administration was very supportive of it because, like I say, we wanted to fix everything at this hospital so that when we moved to the new hospital, we had the best possible equipment and policies and practices in place.
If I can add on to that, one of the common questions that I hear is, how should I get started? You might have up to 200 protocols on a scanner, sometimes even more than that. And it's an overwhelming task to think about how to get this process underway. And one thing I've heard already from two of our panel members is you have to start small. In Dustin's case, they took a look at one protocol and tried to optimize that one protocol, and then before moving on to others. And just what Valerie was saying, starting with those pediatric protocols was the place for them. So you have to choose a small area to start. You can't tackle it all at once.
John, you had a comment?
No,
Yeah.
I was just going to agree with Val. No, I mean, you have to start and make sure that you're doing it. I mean, at the couple of facilities that I work with, they're reviewing that dose compared to the expected dose on a daily basis, and then it goes into report, and they establish that they're going to meet 4 times a year, that dose reduction committee, and that's when they go over the outliers, that those that did not, or exceeded the expected dose.
How many of you are expecting the Joint Commission in the next 6 months? Okay. Any questions that you'd like to ask to get prepared? We learned earlier from the lecture from the Joint Commission that the surveyors are going to be trained in January. So for those of you who expect your survey before January, they may not have all of the information about the new 25 Joint Commission requirements. That might be a good thing. But for those of you after January, they're really going to be well educated. So this is your chance. Anyone want to ask some questions about getting prepared?
I'll dovetail off that.
Please.
I went to the AAPM website, into their online education center where membership can watch some of the previous lectures from meetings, and just re-watched yesterday the presentation from them. And I probably 20 times they used the words medical physicist and accountable in the same sentence. So do your physicists a favor and please engage them. If you don't have them on site all the time, please engage them. I tried to make a point last night when I was speaking that historically a lot of times they don't spend a lot of time on site, folks like us, but typically if you engage them and ask for help, most of the time they're pretty interested to help. I also made the point that it's not free. Unfortunately, there are all these things that are coming down, all these requirements that are being put on folks like you, and you have to find ways to make it happen, and that includes the cost.
Dustin, I think I'm sorry. I think that's a really good point, because everybody is financially constrained, but when you start looking at the additional requirements that we're all facing, we need to make sure that we take advantage of the resources that we have accessible to us. And in our system, we do contract out with Landauer Physics, and we are transitioning, but we aren't just looking at them, Landauer Physics, as somebody who does tube surveys. We need to have them engage and either act as our RSOs or come in and basically help us with with these processes. And we need to make sure, and I need to get the message out to our 20 hospitals, you're going to have to pay for this. This is not something that you paid for before, but these are new requirements. So, it's just something that you have to, it's a reality check.
If I could just add to that too, I know there's a big buzz about all these new requirements, and it's going to be a lot of work, and it's a big change for us. And many of us that have been managers in imaging for years, when JACO came on site, it was a little frustrating at the end of all the hard work you did all year to try and improve things, that the only thing you got dinged for was because you couldn't find lead apron number 22 in surgery. It didn't matter that, you did all these other process improvements. That's what the CEO would say, what happened to lead apron 22, Val? And that was the crux of if you were a good manager and running a quality department or not. So this will give us an opportunity to really make some changes. And I think as long as we start slow and we document and they see that, they'll be fine in the beginning.
Yes, right here. Absolutely. Would you mind if I bring you a microphone?
That's yours.
We're going to let everybody answer.
You have one.
Would it suffice to trend the optimized protocols? We've optimized our protocols with our physicists. I feel like we're ahead of the game there, and we're very comfortable with our protocols. But now there's this little piece about having an estimated range to compare to prior to scanning. That piece I'm not sure we're on top of. And I was wondering, do we trend our optimized protocols and get a median range? Is that what people are doing to get that predicted value, that, you know, that range that you're looking at before you scan? And then the second part of the question is, can I use the AAPM CT guideline to serve as the practice comparison benchmark for those that went over that range?
I think I can answer that. So first of all, there's a number of ways you can approach setting up the expected dose index range. What you talked about, looking at your historical data, is one approach that people have used successfully. And some of the techniques people have used is maybe looking at the 95th percentile as the upper limit for your dose range. Other people
I should mention we have Ratometrics if that's helpful.
Great. So then it enables you to look at that data and do that sort of analysis. Another thing you can do is you can do size-based. The problem with just having one flat threshold is almost all of your alerts will end up being the obese patients where the dose is justified. So one approach I've used is using size-based expected ranges. And then you can allow a little bit more room for the larger patients. So you're not just triggering an alert every time you have an obese patient. The other approach you can use is to use external references to establish those expected dose ranges. There's a number of resources. The AAPM recommendations for dose check alert notification levels is a great resource. There's the ACR dose index registry. There's also some values put out by the Cleveland Clinic. They put out some CTDI and DLP recommendations. There's the, I'm forgetting the exact title, but there's a European guideline out there, and I'm sorry I forget the exact title, but I can make that available to you as well.
And this isn't the reportable dose. I'm hearing that it's less than the reportable range, because we wouldn't want to go to that level before we were concerned.
What do you mean by reportable?
Well, if you go over a particular, maybe it's California, but if you go over a particular dose for a particular exam, then you have to, it's a reportable event.
Are you in California?
Yeah.
Okay.
So I'm assuming all of this is not about that.
Right.
Correct, okay, good.
There's another hand back here.
I was just wondering, there's, on the new Joint Commission requirements, there's an education component for the technologists. I just was wondering what people are doing in terms of that, because it's very vague as to what the expectation is and what you should put into it.
So because we have like 25 clinical physicists at MD Anderson, and luckily one was hired more recently than me, that person was given the job of putting together a slide set. And it's pretty good, but I can tell you that for those who don't have that type of resource, there are a handful of slide sets available for free at aapm.org. If you scroll down a little bit, look at the left-hand side, there's a little, I think it's a blue rectangle among other rectangles, but one of them says CT protocols. If you click that link, find the tab that says dose education, I think, and there are slide sets. One of them is a generic dose education, talks all about CT dose and the factors that affect it, and then there are manufacturer-specific slides as well. And so the working group on CT nomenclature and protocols at AAPM is a big group of folks. It's got maybe a half a dozen physicists on it, and it's got representatives from every CT manufacturer in the world. And some of them only have like 10 or 11 CTs in the United States, but they participate anyway, and we're grateful. But the point being that is that we have good buy-in and good participation, and that's a free resource. So for example, if you wanted to negotiate additional services from your physicist, creating a talk from scratch is very time intensive, and you can simply offer, hey look, we have these free slides, you don't have to prepare them yourself. If you could please present them, that would be helpful. And these slides will be updated as things change because manufacturers want their latest and greatest information available to their users. So this information will be regularly updated. And so when the Joint Commission comes back the next year, oh, was it the same presentation? It's a reasonable question. You can say, yeah, the working group keeps these slides updated.
I think one of the things that I take away from the new requirements, and the key to all this is documentation. You have to make sure that you have it documented. But it's not just the radiation safety component, it's sort of empowering your technologists to be aware of radiation exposure and that the department is working at it. Do they look at the test that was ordered, and if they think it might be wrong, are they empowered to go to a radiologist for clarification? And it's not just for CT, it's even for MRI. They're saying, if your patient is claustrophobic, is the MRI tech empowered to utilize different things to make that patient calmer? So it's like the softer side of education on some of this stuff, but so that they know about image wisely, they know image gently, they're aware that that's a focus in the department.
And sorry, go ahead.
So I want to go back to what I mentioned earlier, is that we did partner with Landauer for the education. And what was key to my hospital directors and my staff is that it was all tied to HealthStream. And HealthStream is the tool that we use within the hospitals, and it's easy. It tracks their compliance to that. It's going to provide them that link that yes, you completed that, and it's going to provide that documentation that Val talked about, and basically be able to prove to the Joint Commission surveyor that all of our technologists have met that. That was a key win for me as far as looking at it from a system-wide perspective. So it's that was a good fit.
John, thank you for that, and I'll just provide a little bit more detail. So we do have a 50-minute Image Gently, Image Wisely course. So it's web-based, and you can launch it through HealthStream if that's the tool you use, or you can get it right on Landauer Academy. And then we also have MRI courses, which can satisfy the MRI requirements. So those are the 2 of the 25 Joint Commission requirements. But we also have courses on fluoroscopy, fluorosafety. So for those of you who are in California, there's an 8-hour requirement for your operators. So we have an 8 and a 10-hour course that is CE. You can get CEs from MD Anderson, and that is also a very good resource. So Landauer Academy, you can just go online and check it out. The next question, I know there was one other right here. Here, we should have just passed down the mic.
I know. Hey, I've been to a lot of conferences where, and it all starts with how you build your protocols and what you base them on. So you have some institutions that base it on age, some base it on weight, some base it on girth. Is there any effort being made to standardize that? Because in my mind, the scanners don't care how much somebody weighs, how old they are, how tall they are, what eye color they have. It worries about how wide they are, and that's how it references the MAS. And it just seems to be all over the place depending on what institution you talk to or what vendor you talk to as to whether they base it on age, weight, or girth. Is there any effort being made to standardize that? Because that's where it starts.
Yep, that's a really, really difficult issue. And until about 6 or 7 months ago, that information wasn't out there. If you look at the age groups, which is how the manufacturers do their pediatric protocols, they have age groups, they are all over the place. And one of the other efforts of that working group that I mentioned is to publish freely available, safe and reasonable protocols. So the first one was brain perfusion, because that was how those folks got burned in California. So we did that a number of years ago. We did routine adult head. We have lung cancer screening protocols up now, adult abdomen, chest abdomen. So we have a bunch of them up there. And so for the last almost 2 years, at least a year and a half, I've been trying to get the pediatric head protocols out. And for a whole host of reasons that could make us all laugh, especially if we're drinking, it hasn't gotten done yet. But we're close. We're very, very close. And one of the key reasons we're close is we finally arrived at a way to standardize how we sort, the taxonomy by which we sort our pediatric patients for these head CT exams. And that's available at Image Gently. Keith Strauss did the work. It's available for heads and bodies. So the work, and it was published in Pediatric Radiology, I think in November. Either way, it's freely available on Image Gently. And if you check that working group site on AUPM.org, the day you see those up, you can know that I'm drinking a beer. So we're this close. We had to, it's been a lot of work, but if you have a physicist who's willing to engage, it's not really straightforward, but there is a high-level strategy or process that Keith Strauss puts forward in the article.
Yeah, and just to add on to that,
He's a dynamite guy, very sharp guy.
just to add on to that, for head protocols, doing age-based protocols makes sense, but when you look at the body data, there's very little correlation between patient age and the patient size. So I think you need to go to some sort of size-based metric. The one that I've seen people use most commonly is the patient weight, because it's easily available. And the Image Gently recommendations are great recommendations. They just came out in November with those new recommendations. They introduced 3 different schemes for modulating, or how aggressively do you want to reduce patient dose for pediatric patients. They have a limited, a moderate, and aggressive scheme, and those are great guidelines to follow.
So I have a question. This is I appreciate the effort that all of you in Landauer is doing in regards to dose optimization. It's really great. Are you working at all with any of the vendors? It's really complicated and it can be confusing, especially when you go from vendor to vendor looking at different equipment. Have you built any relationships there, and what kind of work have you done with them?
Yeah, Landauer has reached out to all the major imaging vendors. There's a number of ways we work with them. One of the primary ways is we make sure all of our physicists get training on the intricacies of their software. Exactly how do you go in and what are the effects of changing each of the parameters? How do you adjust the protocols? How does the iterative reconstruction work? How does that affect the image quality? So we've tried to make sure our physicists are very knowledgeable on that subject. So primarily our interaction with them has been educational.
Thank you. Oh, over here. Olav, while I'm walking over here, can you talk a little bit about what you're doing with the vendors as far as optimizing protocols and bringing those into software?
Can you clarify that?
Well, actually, here, how about I clarified in a moment, but you had a question, so.
I know we're talking a lot about CT, but as I look forward, I know it's probably coming down the road for DR and all the other modality. My techs struggle a lot with that because we've just switched over to DR and a lot of our equipment. Is there any place out there that you can go to see those protocols optimized or anything like that?
For digital radiography?
Yes.
Well, I know that the ACR dose index registry is actually looking, it was actually originally set up for digital radiography, and then they moved to CT. And I've talked with them, they're thinking about going back to including digital radiography as well. There's also some surveys, is it the NEXT surveys? They look at doses people are using for what's the exposure index range and things like that. Are there any other resources people are aware of?
We did a lot of work in our NICUs with our portables that we had, and it was amazing. I mean, with our techs that we had, we just started out with some basic things that this was the acceptable range for a dose. And we just started tracking our techs like on a monthly basis. And what we found was there was a lot of times they were overexposing the patient and underexposing the patient. So we gave them, Tech 1, Tech 2, Tech 3, and we posted all the results. And then I did it again 2 months later. And then on the third one, I just put the names up of the techs. After a while, how many times can you sugarcoat it? Because you had some techs that were doing that study every time getting it in the range, and you had other techs that were all over the board. And it's like that Hawthorne effect. Once you start watching something and techs know you're watching what they're doing, well, all of a sudden they're using their markers now, and they're coning, and they're doing lead shielding. I think you just always have to have it out there. And so we sort of swung the opposite way. We almost went underexposure, because that's what happens, I think, when people think they're all overexposing. But it was a big educational thing that we hadn't been doing, we hadn't been monitoring it. In the matter of 4 or 5 months, it was remarkable how much we got them all to meet that range. And that now the last part we were looking at was, rather than doing it by the age of the child, we were starting to measure girth with calipers and developing that and seeing if we could do a better job on that.
I'm going to come back to Amy's question. I may know what she's referring to. One of the approaches within Landauer has been, how do you go about optimizing protocols in an efficient way, especially when you've got all these different scanners from all these different vendors. And our approach has been to share best practices across our client base. Like I said, we have nearly 100 clients participating in our clinical dose optimization service, and they're all contributing their protocols to a Landauer CT protocol library. And the whole idea behind this is, if we identify a protocol as a problem protocol at a site, we can then look in our library, pull up what are other sites with that exact same scanner model doing across our client base, and which protocols have we looked at in the past and we verified are achieving diagnostic image quality at the lowest dose. And then we share that best practice across our clients.
There was a question over here. Okay.
It's kind of in that vein. I think we've all been trained, this whole AHRA principle, as low as reasonably achievable, and there's a lot of focus on dose, and that's a great thing. We should be trying to get it as low as reasonably achievable, but not to the point where it's not diagnostic. So there's a lot of dose reference level, we've talked about this in multiple sessions where you can go and look at, there's not widely available, but there are dose reference levels for you to look at as far as like where the upper limit is, but where are we on the lower limit? Where like you could look at this protocol by vendor, by body type, and say, hey, if you're in this range, chances are your radiologists are gonna miss something.
Well, I know a lot of times when we would get the ACR data back, we would find in certain cases we were below the 25 percentile. I mean, it meant that our dose was lower than the average that was out there, or the benchmark that was out there. So at that point we said, well, we're sacrificing now image quality. We don't need to go that low. It's not like limbo. You know what I mean? It's not as low as you can go. You want to go as low as you can, but you still want to make sure you retain the quality of the image so that the radiologist can make an interpretation. So we did go the opposite way in some of those cases. We said, no, we can give more radiation here to get the optimal scan. And I think there's also a teaching component that goes with the technologist, because a lot of times when you start lowering the doses, the images might not be as clear, and they'll say, these images are terrible. They've always been taught, crisper, more detail, but really what you want is the best image that the radiologist can use to interpret the disease or make the call. And that's a different way of thinking, and I see that in nuclear medicine too, where the new standards came out and said you needed to use these doses. So I said to my lead tech, well, they're saying for this scan we should only be using half a millicurie. And she says, well, we only use a millicurie. Yeah, but that's like 100% more of what the standard is. So it's a whole logical way of thinking that you have to get them involved in.
They'll hear you, but everyone else won't.
Does anybody have a physician or radiologist champion? Because when you look at CT and you talk about low contrast resolution and low contrast detectability, and when you look at radiologists and their individual preferences, the range is so wide on what's acceptable and what's not acceptable. Even as an old CT technologist, I could scan with this protocol for this physician, for this radiologist, and it was fine. You use it, the same thing for another radiologist. Well, why did you use this? It's not enough, it's too much noise in the image, or there's too much, it's too smooth. So how do you get past that?
Well, we probably lost a couple technologists in the battles because the weekend radiologists wanted one thing, and then you have, so we just went to one radiologist. There's one radiologist that has the final say on changing a protocol. I mean, it's harsh, and maybe that weekend radiologist doesn't like it, but you can't have everybody else changing it for the doctor. So one radiologist, and he can talk amongst his peers, but when he signs off on it, that's the protocol that sticks.
Yeah,
and it really helps the techs then. You put them out of the line of fire.
You need a champion. I'll say one, so we have this little QC image quality requests button in our, in the rad station where the physicians are reading. And if they see something that they have questions about or they don't like, they hit that button, it auto-populates the inquiry with the MRN, the accession number, and if they're logged in correctly, it puts their name in it also. And that goes directly to physicists. And that allows us to then triage the situation, take a look at the contrast report, whatever, and sort of get an idea as to what may have happened. But honestly, most of the time when they say, it's grainy, not enough signal or whatever, most of the time that doesn't need to be repeated. So it's interesting going back to your question about how low can you go? I don't know, probably lower most of the time. But the point I want to make about this question is that those inquiries always go directly to physics faculty. And so we're avoiding like a punitive culture where, the traditional notion of the radiologist being really angry and they run to the technologist and they say, you hosed this exam and it's no good and now we have to repeat it. So I think that's an important thing. Then we we communicate with the CT managers and they have an opportunity to speak to their peer subordinates about how to do this correctly, or was it just a mistake, or did you forget how we do it, or then it's a very cordial corrective process where because once you get into a punitive culture, it's pretty hard to reverse, and it's tough to keep good people around.
So how do you do that in a small rural community hospital? At MD Anderson.
You don't have a button to push? I want to push that button.
Yeah. That's a great question.
Okay, here we've got a good answer from the field. Great.
Can I try to answer the question?
Yeah, here, let's go here first.
I can say we do have a small group of radiologists, and the radiologists did elect the champion. And that supported the technologist. So when you had that one radiologist that went to the technologist and got upset about their protocol, that technologist just kind of said, you know what, I'm going to take it to my supervisor. And then it went up after that. And we took it to that champion, and they went back and educated that radiologist saying, you can't talk to the technologist anymore. This is what we decided. But the radiologist had to elect that champion.
Is that radiologist on your dose optimization committee?
Yes. Well, we don't call it dose optimization committee. We call it medical practice committee for a radiologist, and he is on that committee, yes.
So let me try to answer that a little bit. You could do a number of things. One would be the physician writes down a number of MRNs and accession numbers for when the physicist visits next. If the intervals are too long, that's fine. One thing you can do, which we did in that project that I mentioned at earlier on, I got remote PACS access. So I signed a HIPAA agreement with the institution, and I signed some business agreement or whatever, and so the physician would just text me or email me an MRN and accession number, and I go look at it, wherever I was. When you were a consultant. So, of course, now I can log into any clinical workstation and look at PACS, but in that isolated instance, when there was a motivated radiologist who was very interested in, she was the champion, and she was able to just say, IT, get this person an agreement, we trust him, and we're going to make this work. And it's a direct benefit to patient care. So
Olav,
that's one way you can work around that.
Can you talk about the number of clients where you've also signed a business agreement and have direct access to their dose tracking monitor or other tools to be able to monitor for them?
Yeah, right now out of our clients, I believe all but one of them, we have remote access to their systems to be able to log in and give them that instantaneous response of what's going on. The other thing I want to add on to your question, and that both the comments about going after the quality of the images, each person on that protocol review committee or dose optimization committee plays a critical role. Technologists and physicists each have a very important role, but you could argue the radiologist is the most important role because they are ultimately responsible for the quality of the images that are being acquired. And so their role is to discuss those image quality issues with the physicists and technologists so you can talk through what's happening, why is it happening, what can we do to fix it.
Justin, you talked a lot about physicists, and can you give a sense either on behalf of the AHRA or just on statistics of how many of the imaging physicists out in the United States have experience and qualifications to work in CT protocol management, et cetera, and then kind of what percentage have said that's not really my area of specialty? You get the question.
I have no idea how to answer that. I don't think, is that data available? I don't know if that data is available. So here's what I think. The AAPM worked a long time to come up with a definition for a qualified medical physicist. That definition is publicly available. There are, my opinion is if they've gone through that process and achieved that, basically if they get boarded in diagnostic radiological physics from the ABR, which is an ABMS board, it's the same board that certifies radiation oncologists and radiologists. It's a reputable certification. My opinion is if they've gone through that process is pretty rigorous. I think that they are capable. Not everybody perhaps will have the same relationship development skills, or some people may be informatics wizards or not. Some people may know MR better than others. I mean, everybody's going to have their strengths and weaknesses, but my opinion is if they've achieved that, then they're capable of doing this. And there are going to be plenty of people who haven't gotten ABR certification in various places around the country who are working and are also capable because they've been doing it for 20 years. But I don't have numbers for you. I don't have that data. Sorry.
Okay. Any other questions from the audience? Yes.
You know, I did see something out on the floor today that I thought was really good, is that when you're changing all these protocols, and you're going to change them, how are you guaranteed that the technologist that comes in on third shift is using the most recent CT protocol that you have signed off on? Because a lot of us, I think, still have the books, you know, they're dusty, you know, but there was some places out here that actually on the software that was available, it had, you know, CT protocol of the head, went into effect January 1st, is still in effect, is going to be reviewed in another 6 months. And then you could also see the list of pending protocols that were being considered for revision. And so I think that would be a big help, because as things get changed, techs don't go to that communication book that you have to see what's been changed. So that can be a pitfall where all of a sudden they're using something, and that's something very big on JACO and with the State Department inspections, is how do you guarantee that they know they're using the most recent protocol or the one that's in effect? So.
Yeah, one of the things I've seen, especially at sites that have multiple CT scanners, is let's say you go and you do modify a protocol. You then, if you're using one of those paper books that a lot of people are still using, you then have to print out the new copy, go around to every single scanner, put it in take out the old one, put in the new one, make sure you update it on the scanner, and chances are you're going to miss one. And that's why I've seen a lot of people moving towards electronic protocols, whether it's through their dose monitoring software or whether they do it themselves through Excel or Word, I've seen people do. But more and more I see people moving towards electronic protocols where they have them all in a central database and they monitor them all that way.
We just changed the date and title. And whichever supervisor was the one that changed it, put their initials next to it. So if there's any questions of any of the CT technologists, you go back to that supervisor and say, so on each scanner, dated and initials.
Excellent. Well, we hope this evening we've sparked some curiosity in you on how you can improve patient outcomes and get more compliant with the Joint Commission requirements. We are committed to providing some free resources for you. So if you'd like to stop by the Landauer booth, we're booth 1039. We're kind of back by the lunch area. And we have a packet for you that includes all of the Joint Commission requirements and various services that we offer that correspond, a list of frequently asked questions, top misperceptions of dose monitoring, an explanation of our clinical dose optimization services, and a copy of a survey that many of you took prior to this session, as well as the paper that Dustin referenced on how expensive it is to track and optimize protocols without using a dose monitoring software. So we have these available. If you're not going to be on the show floor tomorrow, some of you are going home, we do have some packets here, but we have most of them at the booth. And I want to thank everybody for having the courage to ask your questions in front of a group. It's been a long day. I know some of you are going to other vendors' parties. Thank you to our wonderful panel for being really helpful.